This online section is being presented to you by AMS University out of Tempe, Arizona. It includes new material published in the National EMS Education Standards in 2009 in response to the EMS Education Agenda for the Future. My name is Wendy Younger. I'm a paramedic educator, and I'll be presenting this program for you on pharmacology. These are your knowledge objectives for this section. And this is the section on pharmacology basics. A paramedic will be learning specific meds which may be administered to a patient who meets the established criteria on the basis of clinical assessment and history taking. Giving the proper medication in an emergency situation is critical to the well-being of the patient as well as for your own protection. There's up until about 1906, there was very little control exercised over the use of medications. Drugs were sold and distributed basically by medicine men, or by drugstores, by mail-order companies, and legitimate as well as self-proclaimed physicians. The ingredients of drugs weren't required to be listed. As a matter of fact, many drug products contained narcotics as well as toxic materials. The first legislation that was passed was in 1906. Congress passed the Pure Food and Drug Act, and the act was meant to protect the public from mislabeled or adulterated drugs. It prohibited the use of false and misleading claims. The act also restricted the sale of drugs with the potential for abuse. The act designated the United States Pharmacopoeia and the National Formulary as official standards. It empowered the federal government to enforce these standards as well. In 1980, the U.S. Pharmacopoeia Convention purchased the National Formulary, and this made the U.S. Pharmacopoeia the only official book of drug standards in the United States. In 1912, Congress passed the Shirley Amendment, which prohibited fraudulent therapeutic claims made by drug companies. In 1914, the Harrison Narcotic Act was passed to control the sale of narcotics and to kind of help try to curb drug addiction or dependence. This was the first narcotic act to be passed by any nation, and it established the word narcotic as a legal term. In 1938, prompted by more than 100 deaths in 1937 from ingestion of diethylene glycol solution of a sulfanilamide, the Federal Food, Drug, and Cosmetic Act was passed. It contained a provision to prevent marketing of a new drug before it was tested properly. It also required that the label list all of the ingredients that were used in preparing the drug and the directions for drug use. In 1952, the Durham-Humphrey Amendment changed the 1938 Drug Act, restricting the dispensing of prescription drugs. Legend drugs must bear the legend, "Caution, federal law prohibits dispensing without a prescription." In 1962, the Kefauver-Harris Amendment required that the safety and efficacy of a new drug be proven before the drug could be approved for use. And in 1970, the Comprehensive Drug Abuse Prevention and Control Act, also known as the Controlled Substances Act, superseded the Harrison Narcotic Act of 1914. It classifies controlled substances by its use and abuse potential. This is the law where drugs were classified into numbered schedules from 1, which were the drugs with the highest abuse potential, to 5, which were drugs with the lowest abuse potential. In July of 1973, the DEA became the sole legal drug enforcement body in the United States. Now, there are other regulatory bodies that are involved, such as the Food and Drug Administration. It's responsible for enforcing the Federal Food, Drug, and Cosmetic Act of 1937. The FDA can seize goods and criminally prosecute individuals who are involved. The Public Health Service is an agency of the United States Department of Health and Human Services. One of their specific duties is to regulate biological products, which include viruses, serums, antitoxins, or other products that are used in the prevention or cure of human disease or injury. The agency examines and licenses these products and inspects and licenses establishments that produce them. The Federal Trade Commission, the FTC, is an agency of the federal government that's directly responsible to the President of the United States. Its principal action with respect to drugs lies in its ability to suppress false or misleading advertising aimed at the public. The Canadian Drug Control. In Canada, the Health Protection Branch of the Department of National Health and Welfare is responsible for administering and enforcing the Food and Drugs Act, the Proprietary or Patent Medical Act, and the Narcotics Control Act. And in terms of international, the International Conference of Drugs began in 1912 when the first opium conference was held at The Hague. Various international treaties were adopted, obligating governments to try and control narcotic substances. These treaties were consolidated in 1961 into one document, known as the Single Convention on Narcotic Drugs. It became effective in 1964. Later, the International Narcotics Control Board was established to enforce this law. A drug is basically defined as any substance taken into the body by mouth, injected into a muscle, a blood vessel, or a cavity of the body, or applied topically to treat or prevent a disease or condition. Drugs have been identified or derived from 5 different sources, primarily plant, animal and human, mineral products, microorganisms, and chemical substances that were made in laboratories. Drugs can be identified by the following 4 types of names. The chemical name is an exact description, okay? It describes the chemical composition of the drug and its molecular components. The generic name of a drug is a non-proprietary name. It's often an abbreviated form of the chemical name. The generic name is used more commonly than the chemical name. Generic drugs usually have the same therapeutic efficacy as non-generic drugs. However, they're generally less expensive. This is the official name that's approved by the U.S. Food and Drug Administration. The trade name, which would also be the brand or proprietary name, is a trademark name that's designated by the drug company that developed and sells the medication. Trade names are proper nouns and the first letters capitalized. The trade name is usually suggested by the first manufacturer of the drug. And the official name of a drug is followed by the initials USP or NF. These initials denote the listing of the drug in one of the official publications. In most cases, the official name is the same as the generic name. There are a number of reference sources out there that have good information on drugs. Okay, the U.S. Pharmacopoeia, of course, is a compendium of all of the drugs that are available in the U.S. market. The physician's desk reference is a enormous thing. The PDR has not only the official book, but it also has a PDR for over-the-counter medications, and they have a drug identification book, and then about halfway through the year, they have another book that they publish with new stuff that just came out. Drug package inserts are actually pretty good also. They have good information describing the product use. Okay, they have valuable information as new drugs are introduced, and you should consult them to become familiar with the product. Now, there are a bunch of different drug handbooks out there. One of the best that I found is the Nursing Drug Reference. It's published yearly, and it includes nursing consideration, side effects, adverse reactions, precautions, interactions, contraindications. It contains an alphabetical listing of commonly prescribed drugs and detailed information on drugs that were recently approved by the Food and Drug Administration. And there's the hospital formulary, okay? Otherwise known as the American Hospital Formulary Service Drug Information, okay? It's also a large book that has an enormous amount of information on drugs, okay? There are a number of other places that you can get information. One of them is the Internet. It can be a good source of information about pharmacotherapeutics. Usually the Internet has the most current information there is. Also, the findings for current research can also be found. This provides details. Most of that will provide details about current drug studies and drug treatment. This next section has to do with handling medications. Okay. First of all of these things can affect drug potency. First of all is temperature. Most, if not all, liquid medications have to be kept within a specific temperature range. Pre-filled syringes, liquid medication like penicillin, they have a range of temperature that not only protects the drug from degrading, but also from getting too hot or too cold. Refer to drug inserts for specifications. Now, light. Some medications are very light sensitive. Nitroprusside, for example, will convert to thiocyanate when it's exposed to direct light. Moisture. Medications should be kept in the original manufacturer's container. Everybody has those cute little pill boxes that they put their nitro in. Well, they're not airtight, and some of them aren't light opaque, which affects the medication. Okay. Shelf life. Medications have a range of useful life. Always check the expiration dates on any medication you could administer. And the medication isn't like a gallon of milk. Okay? When a gallon of milk says it's not going to be good past the 27th of the month, on the 28th it's liable to have lumps in it. Most of this medication has kind of a buffer to it. When there was a nationwide shortage of D50, manufacturers were contacted, and they stipulated that the D50 could have 6 months added to its expiration date, and it would still be safe for use. Now, controlled substances, medication handling of controlled substances has to do with what the DEA wants you to do with it. Okay, they have specific information on purchase, locked storage, administration, and destroying of unused or expired medications. If you use narcotics in your service, you will have protocols that you need to follow in terms of handling narcotics. Drugs act in the body in many ways, and some of those actions are desirable. That's the therapeutic effect. Others are considered undesirable or even harmful. Maybe a side effect. Drugs can also interact with other drugs. The interactions can produce uncommon and frequently unpredictable effects. Okay? And drugs generally exert several effects rather than a single effect. You do need to know that drugs don't confer any new functions on a tissue or an organ. They only modify existing functions. Actions of a drug are achieved by biochemical reaction between the drug and certain tissue components in the body, usually receptors. The actions of a drug are achieved as it interacts with a receptor to stimulate a response. It's known as an agonist. A drug that attaches to a receptor to not stimulate a response or to stop a response is an antagonist. To produce a desired effect, a drug has to enter the body. The drug has to reach an appropriate concentration at its site of action. This process is influenced by three phases of a drug activity: the pharmaceutical phase, the pharmacokinetic phase, and the pharmacodynamic phase. Pharmacokinetics is the study of how the body handles the drug over a period of time. It includes the processes of absorption, distribution, biotransformation, and elimination. And these things affect a patient's response to the particular drug. Now, absorption it involves the movement of the drug from its entry site to the general circulation. The degree to which drugs attain the activity that they need to depends partly on the rate and extent to which they're absorbed. The rate and extent, in turn, depends on the ability of the drug to cross the cell membrane. The drug crosses the membrane through the processes of both passive diffusion and active transport. Most drugs enter the cell by passive diffusion, but some drugs require a carrier-mediated mechanism to help them get across the membrane. The rate of absorption depends on 5 different things. The first one is the nature of the absorbing surface, which is the cell membrane. If a drug has to pass through a single layer of cell, such as the intestinal epithelium, transports faster than if it has to pass through several layers of cell. In addition, the greater the surface area of the absorbing site, the greater the absorption and quicker the drug takes effect. Blood flow. A patient with poor perfusion will delay the rate of absorption. Rich blood supply enhances it. Poor blood supply delays it. If you give a patient a drug subcutaneously and they're vasoconstricted, it's not going to take effect as quickly as a patient that gets an IM injection of the same drug. Also, if you give a drug by IV, it places the drug immediately into the circulatory system where it's absorbed completely and delivered to its target tissue really rapidly. Solubility of drug. The more soluble the drug is, the more rapidly it's absorbed. Drugs that are prepared in oily solutions are absorbed more slowly than drugs that are absorbed in water or isotonic sodium chloride. The pH of the drug environment. In solution, a lot of drugs exist in an electrically charged or non-charged form. A non-ionized drug is fat-soluble, and it rapidly diffuses across the cell membrane. An ionized drug is lipid insoluble, and it generally doesn't cross the cell membrane. Most drugs don't ionize fully following administration. Rather, they reach kind of an equilibrium between their ionized and non-ionized forms, allowing for the non-ionized form to be absorbed. How and to what extent a drug ionizes depends on whether the drug's an acid or a base. An acidic drug, such as aspirin, is relatively non-ionized, and it doesn't dissociate well in an acidic environment, and therefore it's absorbed easily there. A drug that's basic in that same acidic environment tends to ionize, and it doesn't absorb easily through the gastric mucosa. The reverse occurs when the drug is an alkaline medium. The concentration of a drug. Drugs that are administered in high concentrations tend to be absorbed faster than those administered in low concentrations. And in some situations, a loading dose, is given first that temporarily exceeds the body's capacity for getting rid of it. This establishes a therapeutic drug level at the receptor site. Then after that, a maintenance dose is administered to replace the amount of drug that's excreted. So the loading doses are based more on the volume of distribution, which of course body size is an important component, and less on the capacity for excretion. Maintenance doses are exactly the opposite. And the form of the drug. Drug absorption can be kind of manipulated by the pharmaceutical company. An example is a combination of an active drug with another substance that's slowly released, or a drug that resists digestive action. For example, when we're talking about enteric-coated medication. How that drug is administered also affects the rate at which the onset of action starts. Okay, routes of administration also can affect the therapeutic response. Routes of drug administration are enteral, which is any administration along any portion of the gastrointestinal tract, and parenteral, which is administration by any route other than the gastrointestinal tract, or pulmonary, which is by inhalation or through an ET tube, and topical, which would be application to the skin and mucous membrane. Drugs that are administered along any portion of the GI tract are enteral type drugs. It can be orally, rectally, or through an NG tube. The enteral method is the safest, most convenient route. Okay, it's also the most economical, but it is also the least reliable and the slowest. Okay, of any of the routes of administration, because of what you might have in your stomach, what your emotional state is, your physical activity. Okay, this route allows for 4 types of absorption: oral, gastric, absorption from the small intestine, and rectal absorption. Now, if you give something by the oral route, okay, there's a rich blood supply, but very little absorption normally occurs in the mouth. There are drugs that are prepared to be absorbed orally, for example, nitro. They rapidly dissolve in saliva and are absorbed by the oral mucosa, and there's a rich blood supply there, so they actually are pretty fast acting. Drugs that are absorbed in the upper GI tract enter the systemic circulation. They usually bypass gastrointestinal fluids in the liver. Drugs that are absorbed in the stomach and intestines are absorbed into the portal vein system of the liver. They're subject to first-pass metabolism in the liver. In the sublingual route, medication is placed under the tongue. The tablet or spray dissolves. The effects of it are usually clear within a few minutes. Gastric absorption, the stomach also has a rich blood supply, but it's not considered an important site of drug absorption. The length of time a medication remains in the stomach varies, depending upon the pH as well as gastric motility. Altering the gastric emptying rate may alter the rate and extent of drug absorption. Many drugs are administered on an empty stomach with at least 8 ounces of water to ensure that it rapidly passes into the small intestine, and that's where the drug is absorbed. Now, the small intestine itself has a very rich blood supply, and it has a much larger absorption area than the stomach. Most drug absorption occurs in the upper part of the small intestine. Okay, the pH of intestinal fluid is very alkaline, which increases the rate of absorption of basic drugs. Prolonged exposure allows more time for the drug to be absorbed. Okay, an increase in intestinal motility, for example, somebody who's got really loose stools, decreases the exposure to the intestinal membrane and diminishes absorption. So it moves through the body too fast for a lot of it to be absorbed. And rectal absorption, the surface area is not large, but it's very vascular and is capable of drug absorption. Drugs administered rectally are kind of subject to drugs that are administered rectally are subject to kind of varying absorption. Okay, 50% of a drug that's been administered rectally is estimated to bypass the liver after absorption. Now, the drugs that are administered through the parenteral route are administered by injection. The commonly used parenteral routes for administering meds is subQ, IM, IV, intradermal, intraosseous, and endotracheal. Subq route is just for small amounts of drugs. Rate of absorption is usually slow, and it provides a sustained effect. IM is a little different. It's given into the muscles, and generally it absorbs much faster because there's a much better blood flow to that area. IV is pretty much immediate pharmacological effect. Given in the bloodstream, bypasses the absorption process. Intradermal, this route is primarily used for allergy testing and administering local anesthetics, and we don't use this in the field. Intraosseous is given directly into the bone marrow cavity of pediatrics and sometimes adult patients. Agents that are infused by this method are thought to circulate in the medullary cavity of the bone. The length of time from injection to entry into the circulation is thought to be equal to that of the IV route. Endotracheal. This is generally, meds are generally given through the ET tube for one of two reasons. Number one, you can't get a line, or number two, you've gone for the tube first, and you're in the process of getting a line, but you can get some of your drugs down the ET tube. Because of the large surface area in the alveoli, the rate of absorption by this route is almost as rapid as that of the IV route. Medications that can be administered are lidocaine, epinephrine, atropine, and Narcan. It is kind of erratic, and it may be less reliable than IV or IO delivery, and it should be used primarily in adult patients. Administration of 2.5 times the recommended IV dose is recommended when medication is given by that route. The pulmonary route, okay? The pulmonary medication can be administered by inhalation. It can be in the form of a gas or fine aerosol. The most commonly used inhalation meds are bronchodilators, but you can use the pulmonary circulation because it can absorb a number of other meds if necessary, such as drugs that you're giving down the ET tube. Because of the large surface area and the rich capillary network of the alveoli, drug absorption into the bloodstream is pretty rapid. So bronchodilators and steroids that are given by inhalation devices, like nebulizers, it can really get the drug in there quickly and produce some good localized effects. Okay, so kind of to recap this real quick, enteral includes any entry through any portion of the GI tract. Oral is the safest, most convenient, but least reliable and slowest. Sublingual, it's absorbed in the mucosa in the mouth, enters the bloodstream quickly. Parenteral, any route other than the GI tract. Topical, intradermal, sub-Q, IM, and IV. Topical and intradermal is a very slow controlled rate, which can be affected by circulation to the skin. Sub-Q, slightly faster than topical, small amount of drugs. Intramuscular, much faster than other methods due to a plentiful blood supply. And IV or IO, fastest introduction of the drug with the least loss of drug material and immediate response. Pulmonary, immediate entry into the circulation, some loss of drug into the bronchioles, which necessitates an increased dose to be administered. This is one of the changes in the curriculum. Okay, intranasal. Intranasal route is advantageous because it has faster absorption than IM and sub-Q. No needles are involved, so we don't have to worry about needle sticks. Now, the absorption itself can be slowed down by sinus congestion, trauma to the face and the nose, and vasoconstrictors like cocaine. It's most effective when it's given in a mist form. It's administered using an atomizer that is attached to a small syringe. Meds that can be administered include midazolam, fentanyl, Narcan, ketamine, and glucagon. Now, studies are being done on using intranasal administration for seizure meds, pain control in long-term settings like nursing homes and hospice care, topical meds for acute epistaxis, headache therapy, anti-nausea meds, and possibly insulin. The method for giving it is divide the dose and administer half the dose in each nostril. It may need to be increased for administration. Okay, it's kind of the same way if you administer a drug through the ET tube, and that varies from medication to medication. Just check your protocols. If during administration the medication begins to run out their nose, squeeze the nostrils together to contain the runoff, and then document your administration and your effects. Here's a little kid who is having an IM medication, an intranasal administration medication. Now, a drug distribution is the transport of that drug through the bloodstream. It's transported to different tissues in the body, and then ultimately to its site of action. After it's entered the circulation, it's distributed rapidly throughout the body, and the rate at which that occurs depends on the permeability of the capillaries to the drug molecules. Okay? Remember that lipid-soluble drugs readily cross the capillary membrane to enter most tissues and fluid compartments. Lipid-insoluble drugs require more time to arrive at their point of action. Cardiac output and blood flow to the particular area, where the site of action is supposed to be, affect the rate and the extent of distribution to the different body tissue. Generally, the drug is distributed first to organs that have a good blood supply, and that includes like the heart, kidneys, and the brain. And then, depending on its composition, the drug enters tissue with a lesser blood supply, such as muscle and fat. Now, drugs sometimes accumulate at certain locations in the body that act as kind of a reservoir. At these sites, the drugs form reservoirs by binding to specific tissue. As serum levels drop, tissue-bound drug is released from that reservoir into the bloodstream. The released drug maintains the desired level of the drug in the bloodstream, and it might permit sustained release of the drug over time. This allows that pharmacological effect to continue occurring at the receptor site. There's two general processes that create drug reservoirs, and they're plasma protein binding and tissue binding. As drugs enter into the circulatory system, they may attach to plasma proteins, primarily albumin, forming a drug-protein complex. The extent to which that binding occurs affects the intensity, but also the duration of the pharmacological effect of the drug. The albumin molecule is too large to move through the membrane of the blood vessel. So what it does is it traps the bound drug in the bloodstream. A drug bound to plasma protein is pharmacologically inactive. The protein becomes a circulating drug reservoir. The free drug, which is not bound, exists in proportion to the protein-bound fraction and is the only portion of the drug that's biologically active. As that free drug is eliminated from the body, that drug-protein complex kind of breaks down a little bit, and more drug is released to replace the free drug that was metabolized or the body got rid of. Okay? Albumin and other plasma proteins provide a bunch of different binding sites. Two drugs can actually compete for the same site and displace each other. Certain combinations of drugs may be given at the same time, and that competition can cause serious problems. For example, a patient taking a anticoagulant may be given like quinidine. It may displace some of that protein-bound warfarin, and it becomes toxic in the patient's bloodstream, and in turn can cause uncontrollable bleeding. Other things can also influence the binding ability of the drug, include the concentration of plasma proteins, especially albumin, the number of binding sites on the protein, how well the drug actually likes that protein, and the patient's acid-base balance. Various disease states, kind of like liver disease, affect the ability of the body to handle a lot of medications. Those variations in their body systems can result from a decrease in serum albumin levels. Okay, because albumin is manufactured by the liver. And it can also cause a decrease in hepatic metabolism. Those kind of things can result in more free drug being available for distribution to tissue sites. A second kind of drug accumulation occurs in fat tissue and bone. Lipid-soluble drugs have a high affinity for fat, where these drugs are stored. Because fat tissue has low blood flow, it serves as a fairly stable reservoir for drugs. Some lipid-soluble drugs can stay in body fat for as long as 3 hours after administration. Now, other drugs may have an unusual affinity for bone. These drugs accumulate in bone after being absorbed into the bone surface. Now, some of the barriers to drug distribution that, the two primary ones are the blood-brain barrier and the placental barrier. Okay, the blood-brain barrier consists of a single layer of capillary endothelial cells. These cells line the blood vessels entering the central nervous system. They're very tightly joined at common borders by intracellular junctions. That special arrangement permits only lipid-soluble drugs to be distributed into the brain and cerebrospinal fluid. Okay, for example, general anesthetics and barbiturates. Drugs that are poorly soluble in fat, for example, antibiotics, have trouble passing that barrier, and they can't enter the brain. Now, the placental barrier is a little different. It's made up of membrane layers, and these layers separate the blood vessels of the mom and the baby. The placental barrier is not permeable to many lipid-insoluble drugs, so the placenta offers some protection to the fetus. But it does allow the passage of certain non-lipid-soluble drugs, steroids, narcotics, anesthetics, and some antibiotics. If those drugs are given to a pregnant mother, they may affect the developing embryo and cause birth defects. Biotransformation. After the drugs are absorbed and distributed, the body eliminates most of the drugs, first by biotransformation and then by excretion. Biotransformation is where the drug itself is chemically converted into a metabolite. The purpose of that biotransformation is usually to render a drug less active or completely inactive. Now, the liver is the primary site of drug metabolism, but other tissue can also be involved. The plasma, kidneys, lungs, and the intestinal mucosa. Orally administered drugs that are absorbed through the GI tract normally travel to the liver before entering the general circulation. When that occurs, a large amount of the drug may be metabolized before reaching the systemic circulation. They call that first-pass metabolism. This reduces the amount of drug that's available for distribution in the body. Medications affected by that initial transformation in the liver may be actually given much higher doses, or administered parenterally in order to bypass the liver. Individuals metabolize different drugs at different rates. Patients who have liver, renal, or cardiovascular problems are expected to have prolonged drug metabolism. Infants and seniors with degenerative metabolic function experience depressed biotransformation. Infants with their immature metabolic processes, and elders with problems with their metabolism. So you need to consider dosage reductions, particularly maintenance doses, for patients in those categories, because you have to get that cleared by your med director, or you're practicing medicine without a license. Excretion. Kidneys are the primary organs for excretion, but the intestines, lungs, sweat glands, salivary glands, and mammary glands may be involved in drug excretion. Excretion by the kidneys. Now, a drug can be excreted in the urine unchanged, or it can be excreted as a chemical metabolite of its previous form. There are 3 different mechanisms for the excretion of drugs by the kidneys, and I'm not going to go into that. The second is the intestines. They're eliminated through biliary excretion. After the drug is metabolized in the liver, the metabolites of that drug are carried in bile, passed into the duodenum, and then they're eliminated with the feces. Some of those drugs are reabsorbed back into the bloodstream, they're returned to the liver, and then excreted by the kidneys. Some drugs can be eliminated by the lungs. Most of them are drugs that were inhaled. Now, certain things will affect that. For example, the rate and depth of respiration and cardiac output. If a patient is breathing deeply and there's an increase in cardiac output, it promotes excretion. But respiratory compromised or decreased cardiac output can prolong the period that's needed to eliminate those drugs. Excretion by the sweat and salivary glands. Sweat is not really that relevant a way of drug excretion, but it can cause various skin reactions and can also discolor the sweat. Drugs that are excreted in saliva are usually swallowed and then eliminated in the same manner as other orally administered meds. Certain substances given intravenously can be excreted into the saliva, and that may cause your patient to complain about the taste of the drug, even though it was given intravenously. Excretion by the mammary glands. Many drugs or their metabolites are excreted through the mammary glands in breast milk. Nursing mothers are advised not to take any meds except under the direct supervision of their doctor. Mothers usually are advised to take prescribed medications right after breastfeeding. That diminishes usually any risk to the baby. There are certain factors that influence the action of drugs, and they include different things. Okay, one of them is age. For the most part, pediatric and geriatric patients are highly sensitive to drugs, and that's because kids have an immature liver and renal systems. In an older adult, sensitivity is usually because of a decline in their liver and kidney function. Older patients may also have underlying disease processes, and that can create different responses to drugs. Medications for kids are almost always based on body weight or surface area. Now, many drugs are given according to body mass in kilograms. There's this indirect relationship that exists between body mass and the final concentration of a drug in a patient. Okay, so for example, the larger the patient, the lower the drug will the lower concentration of drug will end up in their body. So the average adult dose is determined by a particular process where they determine what amount of drug will be needed to produce a particular effect in 50% of the population. And that population that they use is people between the ages of 18 and 65 who weigh about 150 pounds. So the appropriate drug doses for kids who weigh less than 150 pounds and are less than 18 years of age is almost always based on body mass. There's also a difference in how drugs affect men and women. Now, these are kind of a result partly from size differences. Women are usually smaller in body mass than men are. So they may end up having higher concentrations of the drug when the standard dose is administered without the consideration given to their size. Also, there's differences in the proportion of fat and water in the bodies of men and women. Okay, they can also cause variations in drug distribution. Drugs that affect mood and behavior can be susceptible to the individual's environment and the personality of the user. For example, a sensory overload can affect a person's response to a drug. Temperature extremes and actually changes in altitude may increase their sensitivity also to a drug. A patient's wake-sleep cycle can affect the manner in which a drug is tolerated and absorbed. And pathological states. Illness or injury and the severity of their symptoms can play a role in a person's sensitivity. Illness or injury can affect the type and amount of drug needed to achieve a desired effect. Also, underlying disease processes, especially cardiac, liver, renal dysfunction, can interfere with the physiological action of the drug, as well as delaying or interfering with excretion. Genetics. This can occur, a problem can occur because of inherited diseases. These patients sometimes have enzyme deficiencies or altered receptor site sensitivities. Their responses to drugs can cause these idiopathic or idiosyncratic drug reactions that can be mistaken for drug allergies. And a patient's belief in the effects of a drug can strongly influence and actually potentiate the drug effects. A placebo can have the very same results as a particular drug if the patient thinks it will have the desired effect. In contrast, if they have a lot of mistrust over it, it can lessen the perceived effects. A paramedic can actually enhance the action of a drug by telling a patient that the drug is going to work and when it will take effect. Now, pharmacodynamics is the study of how a drug acts in a living organism. It includes the pharmacological response observed relative to the concentration of the drug at an active site. Once again, most drugs don't confer any new function on a tissue or organ. Rather, they modify existing functions. There are a whole bunch of different theories about how drugs work, but most drug actions are thought to be the result of a chemical interaction between the drug and various receptors throughout the body. The most common form of drug action is the drug-receptor interaction. For the most part, drugs are believed to bind to receptors to produce their desired effects. According to this theory, a certain part of the drug molecule, selectively combines or interacts with some molecular structure, which is the reactive part on the cell surface, and that interaction produces a biological effect. These cell sites are known as receptors. The drug represents the key, the receptor represents the lock. The drug molecule with the best fit to a receptor produces the best response. After absorption, a drug gains access to a receptor after it leaves the bloodstream and is distributed to tissue that contain the appropriate receptor sites. Now, in the pre-hospital setting, the response to drug therapy can be assessed by observing the effect of the drug on the patient's specific physical findings. Monitoring their blood pressure after giving antihypertensive medication or pain relief after administering an analgesic. That's going to tell you whether the drug did what it was supposed to do or not. Each drug has its own characteristic rate of absorption, distribution, biotransformation, and excretion. So the effectiveness of some drugs can't be monitored solely by the patient's response. Some drugs have to reach a certain concentration to achieve the desired effect. These therapeutic drug levels generally indicate ranges in tissue drug concentrations that produce the desired therapeutic response. Now, biological half-life of drugs, the rate of transformation and excretion of a drug determines its biological half-life. The half-life of a drug is defined as the time it takes to metabolize or eliminate 50% of the drug out of the body. A drug is considered to be eliminated from the body, after 5 half-lives have been passed. if you have a drug, for example, that's 100 milligrams, its half-life is 4 hours. Okay, so 50 milligrams are going to be eliminated in the first 4 hours. 25 milligrams will be eliminated in the second 4 hours, and so on. So it's considered to be eliminated after 5 of those half-lives have passed. The half-life of a drug is really critical when you're determining the rate of administration. A drug that has a short half-life has to be administered more often to maintain the therapeutic range in the bloodstream. The half-life of a drug may be lengthened considerably in people that have problems with liver and kidney function. Some disease processes may require a reduction in dosage or the interval between doses to be lengthened. Another thing to think about when you're dealing with drugs is the therapeutic index. The therapeutic index is a measurement of the relative safety of a drug. The index represents the ratio between two factors. The first factor is the lethal dose, 50, or the LD50. This is the dose of that drug that's lethal in 50% of laboratory animals tested. The second factor is the effective dose, or the ED50. This is the dose that produces a therapeutic effect in 50% of a similar population. The closer the ratio is between the two, the greater the danger in administering the drug to human beings. In certain drugs, particularly digitalis type drugs, the difference between the effective dose and lethal dose is small. These drugs have a low therapeutic index. In contrast, there's Narcan, which has an enormous margin between the effective dose and lethal dose. So it has a really high therapeutic index. A paramedic has to be familiar with the drug profiles of any drug that he administers. Not all of this can be committed to memory. So you should make a regular use of references regarding pharmacology, especially the medications that you're using all the time. Paramedics are responsible for safe and effective drug administration. They are personally responsible for each drug they give, legally, morally, and ethically responsible. You need to use correct precautions and techniques when administering meds. Observe and document the effects of those medications. Maintain your current knowledge base regarding changes in pharmacology. Understand the drugs that they administer and what those drugs are going to do. Carefully evaluate patients to identify indications and contraindications. Take a drug history from every patient that you assess that includes the prescribed medications that they take, the over-the-counter meds, the vitamins, the alternate drug therapies like herbal medications, and whether they have any drug allergies or have had any adverse drug reactions. And consult med direction as needed. Don't guess. Once you give the medication, you can't take it back. Now, special considerations for pregnant patients and pediatrics. Before administering any drug to a pregnant patient, you should consider the expected benefits and the possible risks. Drugs given to a pregnant patient may cross the placental barrier. They may harm the fetus or may be communicated to a newborn if they're breastfeeding. The FDA has established category ratings for drugs. Okay, according to the risks to the fetus, and it's category A, B, C, D, and X. Category A drugs Control studies in women failed to demonstrate a risk to the fetus in the first trimester, when medication is most likely to cause a birth defect. And there's no evidence of risk in later trimesters. The possibility of fetal harm appears to be remote. I'm sorry, hold on. Category B. Either animal reproductive studies have not demonstrated a fetal risk, but there are no controlled studies in pregnant women, or animal reproductive studies have shown adverse effects, other than decreased fertility, that was not confirmed in controlled studies on women in the first trimester, and there is no evidence of risk in later trimesters. Category C. Either studies in animals have revealed adverse effects on the fetus, and there are no controlled studies in women, or studies in women and animals are not available. Drugs in this category should only be given if the potential benefits justifies the risk to the fetus. Category D drugs. There is positive evidence of human fetal risk, but the benefit for pregnant women may be acceptable despite the risk, as in life-threatening diseases for which safer drugs cannot be used or are ineffective. An appropriate statement must appear in the warning section of the labeling of drugs in this category. And Category X. Studies in animals or human beings have demonstrated fetal abnormalities. There is evidence of fetal risk based on human experience, or both. The risk of using the drug in pregnant women clearly outweighs any possible benefit. The drug is contraindicated in women who are or may become pregnant, and an appropriate statement must appear in the contraindications section of drugs in this category. Pediatrics. Dosing principles in the pediatric, the infant, and the neonatal patient. Drug absorption in infants and kids follow the same basic principles as it does in adults. A factor that influences drug absorption is blood flow at the site of IM or sub-Q administration. It's usually determined by the patient's cardiovascular function. Now, certain conditions might reduce blood flow to the muscles and sub-Q tissue, and this includes shock, vasoconstriction, and heart failure. The smaller muscle mass of an infant further complicates drug absorption because of diminished peripheral perfusion to those areas. For orally administered drugs, underlying GI function may influence drug absorption. Liquids and suspensions disperse quickly in gastrointestinal fluids. They are more readily absorbed than tablets or capsules. Increases in peristalsis, for example, diarrhea, and lowered GI activities tend to decrease overall absorption of orally or rectally administered meds. Distribution. Most drugs are distributed in body water. This increases in total body water, and extracellular volume can increase the volume of the distribution. Compared with adults, infants have proportionally higher volumes of total body water, 70 to 75%, compared with 50 to 60% in adults. Infants also have a higher ratio of extracellular to intracellular fluid, 40% versus 30%. Higher dosages of water-soluble drugs might be needed to be effective, to have effective blood levels of newborn. Another key factor that affects drug distribution is drug binding to plasma protein. In general, protein binding of drugs is reduced in an infant, so the concentration of free drug in plasma is increased, and that can cause the drug to reach a toxic level quickly. That also, the blood-brain barrier in infant is much less effective. That allows drugs greater access to that area. Biotransformation. Liver enzyme systems for metabolisms are generally mature kind of unevenly. so that the infant has a decreased ability to metabolize drugs. That predisposes them to developing toxicity, especially in those drugs that are metabolized primarily by the liver. Many drugs given to infants have slower renal clearance times and longer half-lives. Drugs that have to be eliminated through renal function are cleared from the body real slowly, okay, in the first few weeks of life. They progress, those renal functions progress pretty much to maturity after the first year of age. Before that age, excretion of some substances through the renal system might be delayed because it's so immature. Now, older adult patients, they have different factors that you have to consider also. Factors that are associated with aging can significantly affect the drugs that they take, including the likelihood of multiple diseases requiring the use of different drugs. They have nutritional problems, they have a decreasing ability to metabolize drugs, and the possibility of decreased drug dosing compliance for a variety of reasons, for example, money. Okay? So age declines in the functional capacity of most major systems begin in young adulthood. They continue through life. Older adults don't lose specific function at a quicker rate than young and middle-aged adults. Rather, they just have less reserves. Decreases in physiological function, cardiac function, maximal breathing are accepted as beginning no later than 45. Decreased renal function has probably the single biggest impact on medication administration and drug clearance in the older adult. There really isn't a lot of evidence in terms of major changes in how drugs are absorbed in the elderly, but the conditions that are associated with age may alter the rate at which some drugs are absorbed. They have altered nutritional habits, a greater consumption of non-prescription drugs, for example, laxatives and things like that, and it changes gastric emptying. They also have less gastric acid and slowed gastric motility, which may have a serious impact, and it can cause unpredictable rates of absorption, especially in drugs that are weakly acidic. Changes in body composition, for example, reduced lean body mass, reduced total body water, and increased fat. So levels of serum albumin, which binds with a lot of different drugs, especially weak acids, also usually declines. That affects drug distribution. It decreases protein binding of drugs. So that means that there's an increase in the amount of free drug in the circulation. The ability of the liver to metabolize drugs doesn't appear to decline consistently with age for all drugs. But there are disorders that are common with aging that can complicate liver function. One example is CHF. Hepatic recovery from an injury, such as alcoholism or viral hepatitis, can cause declines. Now, certain drugs are generally believed to be metabolized more slowly in older adults, and that's usually thought to be the case because of decreased liver blood flow. But it may lead to drug accumulation and toxicity. You have to use a lot of caution when you're giving meds that's metabolized primarily in the liver to a patient who has a history of liver disease. Older patients with severe nutritional deficiencies may also have impaired hepatic function and renal function. This is the most critical factor for clearance of most drugs from the body. There is a natural decline in renal function that occurs with aging, and it's usually caused by a drop in the number of functioning nephrons and a decrease in blood flow. A decrease in renal function caused by decreases in renal blood flow can also occur because of CHF. The result of this is a prolongation of the half-life of a lot of drugs and the possibility of accumulation to toxic levels. Older adults commonly don't comply with their drug therapy. Okay? Non-compliance may be intentional or unintentional, but it rarely affects the administration of emergency drugs. But you kind of have to be familiar with the most common factors that contribute to drug administration problems in the older adults. And this is really kind of critical because non-compliance or errors may actually be a factor in the patient's chief complaint. The most common reasons for non-compliance and medication errors is that drugs are expensive. Older patients may not take prescribed medications routinely or be unwilling to receive medications in an emergency situation. Non-compliance sometimes is a result of confusion, okay, especially if they have multiple prescriptions, different dosing intervals, and they dump all of their pills in that sugar bowl, and they count them out, and then they forget that they took them, and they count them out, and they take them again. Older patients sometimes forget instructions, okay, specifically on the need to complete medications because their symptoms have gone. And when those symptoms go away, they feel like that's the best reason to stop taking them. Sometimes they stop taking them and save them for later. Errors in self-administered medications can result sometimes from physical disabilities, such as visual impairment. And non-compliance may be deliberate. They may be opposed to taking a drug because of past experiences. A careful drug history is really important when caring for older adults. A paramedic should remember that they do have the right to refuse medication. This section covers less common second and third line medications. This is going to review some of the common medications that are carried on ALS ambulances. Now, descriptions are going to be brief and include dosages and changes to the paramedic curriculum as identified by the National EMS Education Standards. These changes will be specifically identified, but changes in administration is strictly driven by your protocols. Okay, some of these meds are not recognized as first-line medications. The drugs that we're going to cover is labetalol, amiodarone, phenytoin sodium solumedrol, Nubane, milrinone, procainamide, mag sulfate, ketorolac, which is Toradol, and Versed. Labetalol, otherwise known as normodyne atrandate. This is an autonomic nervous agent, an alpha adrenergic agonist, beta antagonist, and antihypertensive. The particular actions of labetalol is it's a non-selective beta antagonist. It slows sinoatrial discharge, atrioventricular conduction, causes alpha blockade resulting in vasodilation, which decreases peripheral vascular resistance. It's indicated in hypertensive crisis, especially in hypertension-induced neurological emergencies, where the patient has rising intracranial pressure. Contraindications are asthma, bradycardia, hypotension, heart block beyond first degree. Side effects: bradycardia, hypotension, dysrhythmias, bronchospasm, nausea and vomiting. It can precipitate congestive heart failure in susceptible patients. Doses 30 milligrams IV over 2 minutes, Q 40 to 80 milligrams, Q 10 minutes, titrated to desired effect. Max dose 300 milligrams. PD dose is not established. Procainamide. This is a cardiovascular agent, an antidysrhythmic class 1A. The actions: it depresses conduction velocity, prolongs refractory period. It has negative inotropic and dromotropic heart effects. Its indication is for treatment of ventricular dysrhythmias. VTAC refractory to other agents. It can help maintain normality of the conduction system following conversion of atrial and junctional rhythms. The contraindications are known hypersensitivity, myasthenia gravis, blood dyscrasias, AV block, torsades, asymptomatic PVCs, ditch toxicity, and hypertension. Side effects: use this with caution in patients who have kidney or hepatic problems to prevent toxicity, and it may precipitate conduction abnormalities. The dosage is 20 milligrams a minute, loading infusion to a max dose of 17 milligrams per kilogram until abolishment of the ectopy or hypotension ensues, or the QRS or QT widens, or the max dose is reached. The maintenance dose, if you do manage to convert the rapid rhythm, is 1 to 4 milligrams a minute, titrated to desired effect. Pediatric dose is not recommended, and special considerations are monitor blood pressure and cardiac rhythm very closely. Amiodarone. This is a cardiac agent, antidysrhythmic class 3. It blocks sodium-potassium channels at rapid pacing frequencies, increasing the action potential and the refractory periods. It's also an alpha and beta blocker. It increases the P to R and Q to T intervals, a smooth muscle relaxant, and causes a slight reduction in peripheral vascular resistance. It's indicated for the initial treatment of ventricular dysrhythmias, VTAC, VFib, and atrial dysrhythmias such as atrial fib, atrial flutter, and PSVT, refractory to other meds. Contraindications are known hypersensitivity, bradycardia, and second or third degree blocks. Also cardiogenic shock or severe CHF. The side effects are hypertension, bradycardia, heart block, pulmonary toxicity, as in ARDS, alveolitis, pneumonia, and interstitial pulmonary fibrosis. It can also cause anorexia plus nausea and vomiting. The dose is 150 milligram bolus IV over 10 minutes at about the rate of 15 milligrams a minute, followed by an infusion of 1 milligram a minute over 6 hours. For non-perfusing VTAC or VFib, 150 milligram bolus can be repeated once at 300 milligrams after 5 to 15 minutes. In PEDS, the dose is 5 milligrams per kilogram, IV or IO by rapid bolus, max dose 15 milligrams per kilogram. Special consideration: attempt to correct hypokalemia and hypomagnesemia prior to administration, and it is light sensitive. Mag sulfate. It is a laxative, a replacement solution, and an anticonvulsant. It's an essential element for muscle contraction and decreases excitability of the motor nerve terminals. It's indicated for VTAC refractory to other agents, for torsades. It's a tocolytic agent in preterm labor, and it's used also for acute bronchospasm, which is refractory to other agents. It's contraindicated in heart block or renal disease, and it shouldn't be given to toxemic patients within 2 hours of delivery. Side effects are hypotension, tachycardia, respiratory depression, maternal as well as neonatal, central nervous system depression, and diaphoresis. The dose is 1 to 2 grams diluted in normal saline, administered over 10 to 20 minutes. Higher doses will probably be needed to treat patients in torsades. PD dose is 25 to 50 milligrams per kilogram IV or IM. Dilantin. Dilantin is a central nervous system agent and an anticonvulsant. It's chemically similar to barbiturates. It stabilizes the seizure threshold. It's used in the treatment of ditch toxicity, and its antidysrhythmic properties can treat QT prolongation. It's indicated primarily for treatment of tonic-clonic seizure activity. Contraindications are hypersensitivity, hypoglycemic seizures, bradycardias, and heart blocks, or sick sinus syndrome, which is also known as Adams-Stokes syndrome. Side effects are central nervous system depression, hypotension with rapid administration. The loading dose is 10 to 15 milligrams per kilogram, slow IV push over 30 minutes, or a single loading dose of 1,000 milligrams. The maintenance dose is 4 to 8 milligrams per kilogram, slow IV push. For ditch toxicity, 3 to 5 milligrams per kilogram, slow IV push. In peds, 15 to 20 milligrams per kilogram, slow IV push. Mannitol, or osmotrol. It is an electrolyte, an osmotic diuretic. Actions, it's a hyperosmolar agent. It increases fluid flow through the kidneys. Indications are acute or traumatic brain injury with evidence of rising intracranial pressure. Contraindications are hypotension in a trauma patient, dehydration, acute pulmonary edema, or patients that are anuric. The side effects are hypotension, acidosis, electrolyte imbalances, and use it with caution in patients who have renal failure. The dosage for rising intracranial pressure is 1.5 to 2 grams per kilogram, IV push over 30 to 60 minutes. Pediatrics, it is not used for pediatrics who have intracranial pressure problems, and it may cause transient hypertension. Methylprednisolone, or solumedrol. It's a hormone, a corticosteroid, and also an anti-inflammatory. Action, anti-inflammatory and immunosuppressive. The indications are it's used to decrease inflammation and swelling, in acute bronchospasm, and it can be used as an anti-inflammatory agent for chronic inflammatory diseases. Contraindications are fungal infections and hypersensitivity. Side effects are edema, hypokalemia, hypotension, hypertension, elevated blood glucose level, and congestive heart failure. Dose, it is no longer used for spinal cord injuries, and I believe the dose on that was very high. In some cases, over 2 grams for some patients. Now it's given at a rate of 40 to 125 milligrams IV push over 2 minutes. In peds, it's 1 to 2 milligrams per kilogram IV push over 2 minutes. Vasopressin, or pitressin. It's a hormone, an antidiuretic. It's an antidiuretic that's used to treat diabetes insipidus, used as a vasoconstrictor in cardiac arrest due to VFib, and it is not to be used concurrently with epi. The contraindications are hypersensitivity, chronic nephritis, ischemic heart disease. Side effects are bronchoconstriction, nausea and vomiting, angina, hypertension, dysrhythmias. Dose is a single dose, 40 units IV push in lieu of epi. Nubane. Nubane is a CNS agent, an analgesic. It's a narcotic agonist and antagonist. It's a synthetic opioid agonist-antagonist analgesic with properties similar to morphine. It relieves moderate to severe pain with a low potential for dependence. It's indicated to treat moderate to severe pain. It's used sometimes to slow down labor. Contraindications are hypersensitivity. And its side effects, it's similar to morphine in terms of CNS depression. The dose is 5 to 10 milligrams IV push, Q 3 to 6 hours. PD dose is 0.1 to 0.5 milligrams per kilogram, Q 3 to 6 hours. Toradol, ketorolac. This is an NSAID, an analgesic and antipyretic. It's a peripherally acting analgesic. It has no known effects on the opioid receptors. It's used for moderate to severe pain management. Primarily musculoskeletal pain, but they also are having a lot of success using it with patients who are not reacting appropriately to morphine when it's being given for kidney stones. Contraindications are hypersensitivity. You can't give Toradol to patients who have an allergy to aspirin. It's also contraindicated in labor and delivery, in patients who have severe renal problems, patients with risk of bleeding or peptic ulcer disease, and it should not be used in conjunction with other NSAIDs. The side effects are headache, GI distress, and nausea and vomiting. The dose is 30 milligrams IV push up to the age of 65. If they're greater than 65, a single dose of 15 milligrams IV, Q 6 hours. This also can be given in a pill form. PD dose is 2 to 16-year-olds, 0.5 milligrams per kilogram to a max dose of 15 milligrams. Primacor, milrinone. This is a cardiovascular agent, an inotropic agent, and I don't know what classification this particular medication has. Its action, it increases contractility and direct arterial vasodilation with little chronotropic effect. It's used in the short-term treatment of CHF on patients who are taking digitalis and diuretics. It can increase cardiac output and drop pulmonary capillary wedge pressure and peripheral vascular resistance without increasing myocardial O2 demand. It's contraindicated in patients who are hypertensive, who have severe aortic or pulmonic valve disease, hypersensitivity. The side effects are dysrhythmias, both ventricular as well as supraventricular in origin, hypotension, chest pain, cardiac ischemia, and thrombocytopenia. The dose is a loading dose of 50 micrograms per kilogram IV push over 10 minutes with a maintenance infusion of 0.375 to 0.75 micrograms per kilogram a minute. The PD dosage has not been established. And last but not least, Versed, midazolam. This is a CNS agent, a benzodiazepine, anticonvulsant, sedative hypnotic. It's a short-acting benzodiazepine with hypnotic, sedative, and amnesic properties. It's indicated for sedation, used to suppress seizure activity, and as an adjunct to endotracheal intubation. The contraindications are hypotension, decreased level of consciousness, hypoperfusion, intoxication, and narrow-angle glaucoma. The side effects are hypotension, tachycardia, bradycardia, respiratory depression, altered LOC. The dose is 1 to 2.5 milligrams, slow IV push over 1 to 2 minutes. It can also be given IM. And the PD dose is 0.05 to 0.2 milligrams per kilogram, slow IV push, over 3 minutes. That concludes the section on pharmacology. Thank you.